Assalamualaikum. I am Nurul Suhaili Ibrahim from OUM Alostar. My metric number 9305-090-7515-4001. Bachelor of Medical and Health Science. This is a case study, cardiogenic shock in acute myocardial infarctions for NBCP 2424, clinical practice and ambulance service. I was posting to Bukit Mertajam Hospital. My case study is about Mr. Pervanatiran anak lelaki Subramaniam. He is 60 years old, male, received case from call center from a young lady that report her father was having left-sided weakness and numbness. Transport from Taman Impian to emergency department, Hospital Bukit Mertajam, accompanied by medical assistant. The primary triage is tagged a non-trauma case in the red zone. The patient dizzy, lethargic looking, conscious, and the vital sign, blood pressure is 60/30. Radial pulse is 40 beats per minute. SpO2 reading is 92 to 97% via room air. The patient's chief complaint is he started develop nagging left arm. Pain radiated up to his neck and down his finger, along with diaphoresis, flushing, short of breath, no fever, no URTI, no AGE, no slurred speech, and no facial deviations. Patient demographic data. Sex is male, race Indian, age is 60 years old, religion is Hindu, marital status married, occupation retired, number of siblings is unknown, hobby is nil. General health history, patient smoking, alcoholic, social history, retired from a government servant as a clerk, past medical history, diabetic type 2, hypertension, on medication, and dyslipidemia. Past surgical history is nil. Family history, father passed away because of myocardial infarctions. Investigations, physical examination, history collections, echocardiogram, chest x-ray, and perform ECG immediately to help diagnose myocardial infarctions. Lab study is full blood counts, cardiac enzyme for creatinine kinase and CKMB, TROP-T, atrial blood cases. This is ECG before angiogram. The investigation finding is ECG show junctional rhythm with ST elevation in lead 2, 3, and AVF. Echocardiogram was done, the patient EF about 30 to 40%. Full blood count, HB is 10.5, RFP, creatinine 172, EGFR 35.4, CK is 1111, TROP-T is more than 2000. Management treatment, cardiac monitor and vital signs, oxygen via high flow mask 15 liters per minute. IV atropine was given because of heart rate is below than 40, IV dopamine and IV noradrenaline. IV morphine given 3 mg because patient having a pain, together with Mesalon 10 mg. Antiplatelet was served, tab Brilinta and tab aspirin prior to angiogram. Patient sent to Hospital Pulau Pinang for PCI, primary PCI, and further investigation. Further management, temporary pacemaker was inserted, Patient was done angiogram and PCI on LAD artery, the culprit lesions with one stent, revascularizations. Patient was transferred from cath lab to ICU care for cardiac monitorings and monitor for any these arrhythmias, cardiac rehabilitations. This ECG is after coronary angioplasty was done with a temporary pacemaker pacing. Shock, defined as inadequate tissue perfusion, can caused by various diseases that result in decreased oxygen delivered to the cell. Commonly occur when circulatory failure manifests as hypotension. Type of shock: hypovolemic, cardiogenic, neurogenic, anaphylactic, and septic. Incident on cardiogenic shock. Cardiogenic shock occur as serious complication in 5% to 10% of patients hospitalized with acute myocardial infarction. The most common cardiogenic shock happen in a man than a woman because of their high risk of coronary artery disease. Cardiogenic shock definition. Cardiogenic shock occurs when the heart ability to contract and pump blood is impaired and the supply of oxygen is inadequate for the heart muscle and the tissue. It's a major and often fatal complications of a variety of acute and chronic disorder, whereby the heart muscle fails to effectively pump blood forward and is unable to maintain adequate tissue perfusion. It most commonly occurs in association with and as direct result of acute myocardial infarctions. Acute myocardial infarction is the most common cause, and early recognition of cardiogenic shocks is essentially etiology. The cause of cardiogenic shock are known as either coronary or non-coronary. Coronary cardiogenic shock is more common than non-coronary cardiogenic shock, and it's seen most often in patients with myocardial infarction (MI). Severe impairment of myocardial performance that result in the diminished cardiac output and organ hyperperfusion and hypoxia. Also, cardiac arrhythmias. The pathophysiology. Cardiogenic shock is characterized by systolic and diastolic dysfunctions leading to an organ hypoperfusion. The interruptions of a blood flow in an epicardial coronary artery cause the zone of myocardial supply by the vessel to lose the ability to shorten and perform contractile work. Decrease coronary perfusion pressure and the cardiac output, as well as increased myocardial oxygen demand, play a role in the vicious circle that lead to cardiogenic shock and potential death. Causes of cardiogenic shock. Mechanism of cardiogenic shock. First, severe left ventricular dysfunctions, new plus minus pre-existing dysfunctions. Second, severe right ventricular dysfunction with or without LV dysfunctions. Arrhythmias secondary to ischemia. Acute myocardial infarctions with mechanical complications. First, papillary muscle or caudal rupture, resulting in a mitral regurgitation. Second, left ventricular dilatations leading to failed mitral leaf coaptations. Third, ventricular septal rupture, free wall rupture. The last one, ascending aortic dissection involving coronary plus minus artery valve. The risk factor: extensive damage to the left myocardium, large anterior wall myocardial infarction, LV mass loss, age below than 70 years old, sinus tachycardia, heart rate is 110 above per minute, bradycardia rates below 60 per minute, anterior ST elevations, increased time from onset ST-MI, multi-vessel coronary artery disease, myocardial infections, or angina. The clinical manifestations is hypotensive, absence of hypovolemia, clinical sign of poor tissue perfusion, skin is usually ashen or cyanotic and cool extremely or molted. Peripheral pulse are rapid and faint and may be irregular if arrhythmias are present. Chest pain. Patients also show signs of hyperperfusion, such as altered mental status and decreased cardiac output. Diagnosis is from ECG. A is characteristic of ST segment elevation caused by ischemia. Convex, straight upsloping, straight horizontal, straight downsloping ST segment. ST segment elevation caused by ischemia typically display a convex or straight ST segment, such as ST elevations is present of chest discomfort or strongly suggestive transmural myocardial ischemia. Typical non-ischemic ST segment elevations. Non-ischemic ST segment elevate are extremely common in all populations. They are characterized by concave ST segment and a greater distance between the J point and the T wave apex. Example of ST segment elevation by ischemia. ST segment elevation can vary markedly in appearance. There are 6 examples were retrieved from 6 different patients with ST elevations MI. Real-life lead show. Example, ECG from a male patient aged 61 who experienced chest pain while driving to work. Note ST segment elevation as well as reciprocal ST segment depression. There are also pathology QAs in lead 2, 3, and perhaps AVF. Management. To reduce pain after pain is not relieved by 3 doses of GTN isocat given 5 minutes and opioid analgesic such as morphine or betadine can give to the patients. Oxygenations give a 15-liter high flow mass oxygen to the patient, maintain blood volume, manage a cardiac output. Shazak give a prosumide indicate of pulmonary wedge pressure is more than 20 mmHg. It decreases cardiac preloads. You also can give vasodilation (GTN), inotropes agent like dopamine, adrenalines, and noradrenalines. Treatment of arrhythmias. Shazak give amiodarone. Prevention thromboembolism. Fibrinolytic agents like streptokinase to achieve reperfusion of infected area. The thrombolysis should be started within 1 to 3 hours of MI symptom onset. Mechanical support. In general, mechanical support can be classified as tools to be used for short or versus long-term deploy percutaneous versus surgical or based upon their mechanism. Such as intra-aortic balloon pump (IABP), percutaneous ventricular assist device, extracorporeal membrane oxygenation such as ECMO. Prevention. Patient must stop smoking and alcohol. Patient also need to do exercise 3 times a week, control diet, and take antiplatelet as prescribed by a doctor. Manage a lipid profile, such as LDL, must be lower than 1.4. Control hypertension and diabetic management with follow-up HbA1c 6 months. Last but not least, conclusions. Management of cardiogenic shock in acute myocardial infarct requires rapid, sustained, and early restoration of flow in the infarct-related artery to minimize myocardial damage and to improve clinical outcomes. Cardiogenic shock is a potentially fatal complication of acute myocardial infarction and other heart disease. Okay, thank you for listening my presentation of cardiogenic shock in acute myocardial infarctions.